Hello, my name is Addison Wright, and I will be talking about glycogen storage disease. There are many types of glycogen storage diseases, and they all result from a defect in one of the many enzymes involved in glycogen metabolism. GSD1A is the most common type and results from a defect in glucose 6-phosphatase, the enzyme that converts glucose 6-phosphate to free glucose in the liver. As a result, the liver is unable to produce glucose for the body by gluconeogenesis or glycogenolysis, which are the principal pathways used by the liver during fasting conditions in order to produce glucose. GSD1A results in the accumulation of glycogen in the liver, leading to decreased hepatic function, constant hunger, hypoglycemia, and increased purine synthesis, which in turn leads to increased levels of uric acid in the blood. In a study conducted by Dos Santos et al., researchers assessed the nutritional status of patients receiving uncooked cornstarch as a method to treat GSD1A. This is a common method used for controlling fasting hypoglycemia. 25 patients with GSD1A and 25 healthy controls were included in this study, and the nutritional status and body composition of all participants were evaluated using bioimpedance. Researchers found that height was significantly reduced in patients compared to controls, also that BMI and fat mass percentage were higher in patients, and that patients had significantly higher adiposity than controls. In a study by Mellis et al., researchers evaluated the prevalence of metabolic syndrome and insulin resistance in patients with GSD1A and 1B. This prospective study followed patients with GSD1A and B for 10 years and recorded the clinical and biochemical markers of metabolic syndrome and insulin resistance. 10 GSD1A patients and 6 GSD1B patients completed the study, and at the end, the data was compared to 10 and 6 controls, respectively. Researchers noted that at baseline, 20% of GSD1A patients had been diagnosed with metabolic syndrome, while 80% showed multiple criteria for metabolic syndrome. At the end of the study, 70% of GSD1A patients had developed metabolic syndrome, and 30% showed multiple criteria for metabolic syndrome. Researchers also found that patients suffering from GSD1A had higher BMI compared to controls, and also had higher serum cholesterol, lactic acid, uric acid, and insulin serum levels. In a study by Corlin, Jaleska et al., researchers presented the case of a patient with GSD1A who was suffering from multiple comorbidities. The patient was a 23-year-old female who had been diagnosed with GSD1A at birth. The patient had a BMI of 32.5, was suffering from hyperuricemia, hypertension, dyslipidemia, and elevated cholesterol levels. For the intervention, researchers administered frequent feedings of cornstarch throughout the night and day to avoid hyperglycemia. As a result, the patient's BMI decreased to 28. She had improved lipid status, lowered cholesterol, and uric acid levels. So what is the metabolic impact of GSD1A? In patients with GSD1A, the liver cannot form free glucose from G6P, which leads to an increased level of G6P building up in the body. So G6P can be used for the pentose phosphate pathway, de novo lipogenesis, triglyceride synthesis, or cholesterol synthesis. If used for the pentose phosphate pathway, G6P is converted to 6-phosphogluconate, then ribulose 5-phosphate, then ribose 5-phosphate. Ribose 5-phosphate is used for purine synthesis, and increased catabolism of nucleotides leads to increased production of uric acid, which is why high levels of uric acid, known as hyperuricemia, is so often seen in patients with GSD1A. This pathway also produces NADPH, which can be used for fatty acid synthesis. If used for de novo lipogenesis, G6P enters the glycolytic pathway and produces pyruvate, which is converted to acetyl-CoA. Acetyl-CoA is then used for the synthesis of fatty acids. Acetyl-CoA produced from G6P may instead be combined with acetoacetyl-CoA to form HMG-CoA as part of cholesterol synthesis. This formation is the rate-limiting step of cholesterol synthesis. If used for triacylglycerol synthesis, G6P is converted to dihydroxyacetone phosphate, which is reduced to form glycerol 3-phosphate, which is the activated backbone for synthesis of triacylglycerols. All of these pathways may result in an increased production of fatty acids, which in turn may result in increased adiposity seen in patients. The significance of this is that the symptoms and comorbidities associated with GSD1A may be reduced with proper treatment. Close monitoring of diet is extremely important in patients, and careful attention must be paid to amount and type of carbohydrates consumed in order to avoid excess G6P production. In turn, this can reduce the excess synthesis of fatty acids or nucleotides, which can lead to a decreased risk of adiposity and or hyperuricemia in patients.